Good afternoon, everyone. COE STM Kolkata welcomes all the participants for today's RDLS session. Today's topic is SACEP referrals and follow-up, and the speaker is Dr. Nivedita Dutta. Dr. Nivedita Dutta ma'am has done her MBBS and MSc in Clinical Research and Regulatory Affairs, PDCR, is presently working as Senior Medical Officer, Clinical Research Fellow at the Center of Excellence in HIV Care with the School of Tropical Medicine, Kolkata. She is actively involved in various HIV-related research projects and has attended conferences and published articles in international journals in the relevant field. We welcome you, ma'am, for today's session and request you to start the session.
Yeah, thank you, Sweta, for the kind introduction. Today, my discussion topic is about the SACEP referrals and the follow-up. I will be speaking in English and also sometimes in Hindi. Hopefully, that will help everyone with the learning. Now, my topic for today is the objectives of my topic today is basically introduction to how SACEP is, who builds up the SACEP, what is the mechanism and the modalities of the SACEP. Basically, it is a state AIDS clinical expert panel, as we know, assessing the treatment failure and adherence monitoring at SACEP, comprehensive guidance on the VL testing according to the NACO OM 2nd May 2024. I will be talking about the drug-drug interactions, adverse drug effects, and case discussions on some SACEP specific cases. Now, highlighting the importance of ESC in treatment failure, and I also will be talking about some adverse drug reactions. Now, coming to the introduction about SACEP, we all know by now that we have a state AIDS clinical expert panel, which are situated at the Center of Excellences or the ART plus centers in few states. And the role of SACEP is to review the cases, the referrals that are sent by the home centers. The referrals are mostly the failure ones and other opportunistic infections for appropriate ART or for any other issues. And for timely switch of the drug or the substitution of the drug, SACEP has to intervene because SACEP needs to screen the patient, evaluate the patients, and the experts give their advices on what is the next best regimen for the patient. Now, coming to the mechanism and the modalities of SACEP, we know by now that we have one e-SACEP, we have a tele-SACEP, and we also have a physical SACEP. These three are at present running in our program. What is e-SACEP? When the reference center sends a referral with ART history, viral load test results, latest and the serial CD4 test results, treatment adherence details, other relevant clinical details in the referral form, and the replies are shared with the centers by email only. For eSACEP, the communication is totally online, that is by emails, and we do not see the patients here. Neither do we talk to the SMO or MO. It's basically purely a paper or based referral system. But for e-SACEPs also, it is important that like, for the failure cases, if we ask for the telephone numbers, and if the experts at SACEP feel that they need to talk to the patients in between before sending a reply, they talk to the patients, ask about the adherence, ask about issues related to the adherence, other questions they might be having. So e-SACEP is a referral system when the email is the main mode of transmission of the answer and the questions. And now coming to the tele-SACEP, here we have a e-SACEP referral procedure. ART center and SACEP are connected virtually. Then the ART center presents the cases to the SACEP in presence or absence of the patients. Here, the ART centers, they fix a date and according to the convenience of the SACEP experts, and we have an pre-appointment, and there's a tele-SACEP where both the experts at the ART Plus and the COE, they sit together. If the patient is able to attend the SACEP, it's best at the home center level. And then the SACEP evaluates the cases and they give recommendations. So these are the two basic things, e-SACEP and the tele-SACEP. And it's very important that when the telesasep is happening, that the physicians, the ART SMO or the MO is present at the time of the telesasep, because he or she is the best person to give a detailed clinical history of the patient. And also the counselors can add on to the ESC and the adherence part. Like the benefits of e-SACEP and tele-SACEP is basically that it reduces the turnaround time for SACEP review, reduces the need for multiple communications between the ARTC and the SACEP, provides an opportunity for mentoring and capacity building, can be used for patients needing in-person consultation, thereby avoiding the need for travel. So telesasep is by far the best mode, because in e-SACEP sometimes what happens, if the communication is only by email, there are multiple communications, because we keep asking for small details, small investigations, and there are multiple communications. So the patient might be lost in the multiple threads of communication or email. But in telesasep, whereby the ART plus, the COE, and the home center, they are all sitting together in an online meeting, there are least chances of losing the patient, losing follow-up. And if COE or ART plus feels at any point of time, we are the treating doctor is present, the treating counselor is present, and if the patient is present also at the farthest end of the home center, it's very easy for the SACEP evaluation, because we get the queries answered then and there. So e-SACEP is good, but tele-SACEP is by far the best modality. Now coming to who should be referred to SACEP. SACEP, we, as of now, we all, most of us, we know suspected ARV treatment failure, ARV adverse effects, drug-related complications, and the patients from the private sector who are on a regimen other than the preferred first line, second line guideline for the NACO. When they enter, sorry, into the program, the SACEP is necessary to uh, decide the perfect regimen for the patient. Now, coming to the treatment failure, by now we all know that there is a virological failure, immunological failure, and there's also a clinical failure. Now, what is virological failure? Loss of antiviral efficacy and triggers the switch of the entire first line regimen to the second line or beyond. And how do I certify that a patient has having virological failure? When the viral load test we do usually regularly for our patients now. It's available all over India at all ART centers. And we are very fortunate now to have these facilities under one umbrella. And now the viral load, if it goes above 1,000 copies at or after 6 months of ART with more than 95% treatment adherence, then we call this or classify this as a case of virologic failure. That is, the viral load that is done at the ART center level shows that the virus count is more than 1,000. In Western countries, the cutoff is much lower. In some countries, it is 200. In some, it is 400. But for the operational issues, as we have to target a few million patients with us, so it's for operational issues. The target for NACO in our country has been considered as 1,000 cutoff. And if the virologic count is more than 1,000 and the patient is on ART with good adherence, this is very important, because if their adherence is poor, we cannot classify the case as virologic failure. If only and only if the adherence is more than 95% minimum, then we can call, oh, my patient is failing in spite of taking the ART properly. So adherence is very important before tagging a patient as having virologic failure. So, and the minimum duration of ART that a patient should be taking is 6 months. Before 6 months, we will not be testing the patient for virologic failure. Now, coming to the suspected immunological failure or clinical indicators, but needs a confirmation of unsuppressed viral load. Now, basically is when we are going for CD4 testing, as we all know now, that we are not regularly doing CD4 for our stable patients, but for patients who are showing a CD4 count of 250 or less, or are having a clinical failure. For those cases, we need to do a CD4 and a persistent CD4 of less than 100. These are the cases where we have to identify patients whether they are going through an immunological failure or not. We have to repeat the CD4 if needed. If a patient is having a cold and cough or a severe acute diarrhea during the phase of CD4, it is expected that the CD4 might go down a bit, it might dip a bit. So what we can do is we can ask the patient to repeat the CD4 after 4 weeks of wellness. So if the repeat CD4 also shows the below a count less than 100 or a count less than 250 or just at 250 with some amount of clinical failure, then it is tagged as immunological failure. But the immunological failure cases need to be confirmed by a virologic test. As the virologic reports are available, results are available throughout India, there's no point in just relying on the CD4 count. Now, coming to the clinical failure, what is a clinical failure? New or recurrent clinical event indicating severe immunological immunodeficiency after 6 months of effective treatment. That is WHO clinical stage 4 condition. My patient is on ART for more than 6 months and he is stable on ART, like he hasn't missed his pills, neither has he missed his visits on time. In spite of that, patient has a new stage 4 condition. So this 6 months is important because it might be also a case of IRIS. So to exclude that, we need to confirm that the patient has taken ART for more than 6 months. And after 6 months of ART, patient is having a new OI, stage 4 OI. So we will suspect clinical failure in these cases. So, before identifying treatment failure, factors which are important are ART duration. It has to be 6 months or more. It should be a new OI, nothing that is a relapse or anything. It has to be a new OI, or IRIS can be also there. So it has to be considered that if we are not seeing a case of iris, that has to be excluded. And at the same time, we have to look into the stage 4 OI, which will give us an indication that the patient is having clinical failure. So the treatment failure is any one of these confirmed by virologic failure. Now, coming to treatment adherence, what has to be assessed? As I said, that if a patient is not on ART properly, then the high virologic count does not hold any meaning. So, treatment adherence, a detailed assessment of adherence needs to be made. The reasons for non adherence need to be explored. Unless these reasons are identified, the patient will find it difficult to adhere to the second line regimen. So, the point here is a patient who is failing on first line is quickly shifted to second line. I did not go into the factors which are leading to the failure. So, what am I doing here? I am simply ignoring the causes which led to the failure. If this is happening, what am I doing is I am switching the patient very rapidly to second line. But the reasons for which the patient could not take the first line medicines remain there. So the second line will also not be showing good adherence. So the factors which led to the failure of first line need to be explored very nicely. There can be factors like social issues, there can be factors like local issues, like financial issues. We really need to talk to the patient. If a patient has an oral ulcer, persistent oral painful ulcer, for which he cannot swallow medicines or big tablets, if I switch the regimen very rapidly without treating his ulcer, suppose a patient is having CMV esophagitis or any other esophageal infections or any other gastric problems or any other illness which is hampering his normal life. So we have to look into these issues without treating them. If we just switch the ART regimens very frequently, it doesn't help, because if the issues for non-adherence are persisting, the patient will fail second line in also no time. Suppose for a pregnant lady, we did not look into the issues of her having recurrent vomiting during her first trimester, and we just simply switch the drug. We can switch the drug in pregnancy. Sometimes it is important to switch the drugs regimens rapidly, but that does not mean that the adherence will be 60% and I'm switching the drug. So what I need to do is I have to add antiemetics. I have to counsel the patient. I have to alter the timing of food along with the medicines. I can split the number of medicines if they are more than one. So these are the things that we have to look into the we have to literally explore the reasons for non-adherence. This is very important, and that is why I'm talking so much about this treatment adherence. Now, the drug-drug interactions is also important. A patient on PI-based regimen like atazanavir, who is also taking PPIs or the proton pump inhibitors like omeprazole, pantoprazole. So the as we know that ATVR, it needs a low or pH or acidic pH for absorption. Now I am increasing the pH to a more alkaline side by the PPIs, so the absorption of atazanavir is reduced. Again, with the calcium medicines and the zinc containing vitamins and also the magnesium containing antacids, if they are given with dolutegravir, that they are basically chelating dolutegravir, so dolutegravir blood level will fall. So I also have to look into the drug-drug interactions. Like if a patient is on rifampicin and the patient is taking only a single dose of dolutegravir, then the dolutegravir blood level will be falling. So these are the things that need to be seen by the physician at the ART center level. These cannot be seen by the counselors. So identifying the root causes of poor adherence to a medicine is very important. And the doctor has to see side by side with the counselor what are the reasons my patient is failing, even in spite of taking the medicines? Certain OIs and the occult malignancies may lead to the decline in the CD4 count. We all know that malignancies, they like rapidly decrease the WBC count, especially if the patient is on chemotherapies, and expectedly the CD4 count will also fall. That there are opportunistic infections which lead to a low count of the WBCs like typhoid and some other infections. In these, there is leukopenia. And if a patient is having pancytopenia or leukopenia, then in those cases, the CD4 will also reflect a low count. Now, coming to the adherence monitoring. So, what are the things that give us an indication that how do we follow a case of poor adherence? On-time pill pickup is important. I have to check the dates, whether the patient is adherent to the dates or not. Number of doses missed since the last visit, that is very important. How many doses has the patient missed? Whether the doses are taken at correct time interval. Sometimes the zidovudine is not taken at a 12-hourly interval. Whether a patient is taking at 12 o'clock in the noon time, and the second dose he is repeating at around 7 o'clock in the evening. So it is an improper dose because we will be having a dip in the blood level around midnight. So the number of doses, whether the doses are taken at the correct time interval, reasons for missing the incorrect dosing or non-adherence, as I said, and the timing and the dosage of the concurrent medications, that is also important. So drug interactions can be avoided if we maintain a gap with the medicines. As we all know by now, like we are giving dolutegravir TLT regimen to most of our patients, and in these patients we need to counsel our patients that if you are on any calcium supplements, if you are taking any iron supplements, any zinc containing vitamins, aluminum hydroxide containing liquid antacids or the chewable antacids, then in these cases you have to maintain a gap of 6 hours with your dolutegravir so that dolutegravir does not interact with these drugs, and we want best bioavailability with our drugs. I do not want my patient to have a low blood level in spite of taking the pills. So it is very important to see the concurrent medications which he is taking. Now, the checking adherence is important. By the most popular two methods are we ask the patients how many tablets are missed. We are also looking into the pill count and the bottles. So the bringing the bottle at the end of the month is very important. How many pills were issued needs to be seen last time. How many are remaining in the bottle and on what date he was supposed to come. This gives us a lead into the percentage calculation of adherence. So the adherence is nothing but simply how many tablets have I taken by how many tablets should I have taken. Like so that is how many I have consumed by divided by the denominator is how many should I have consumed in the same period of time. Into 100 is a percentage. Suppose I'm illustrating a case like last visit I had one pill in my box. I was issued 30 pills in the next visit. So the total number of pills I have taken home is 31. Now I come after 30 days at the ART center with the 3 tablets remaining. So what happens is I have come after 30 days. I had 31 tablets. So I should be having only 1 tablet extra, but I have 3 tablets extra in my box. So basically, I have my basic consumed only 28 tablets in 30 days. So what I have consumed is 28, that is the numerator. What I should have consumed is 30, that is the denominator, into 100 as percentage gives 93.3%. So calculating the adherence is pretty easy, but we have to remember for multiple drugs, like if a patient is on second line with ZLA-TVR, if a patient is on third line with DRVR, and because these are separate pills, DRVR, TLD, sometimes an extra dose of dolutegravir, only the least adherence should be highlighted as the total adherence of the patient. Not, we will not consider the maximum ones. We will only highlight the minimum ones. Now, the chronology and the identifying treatment failure, I think we have all gone through these slides many a times. Treatment failure is the earliest to appear. Basically, there are opportunistic infections that crop up slowly. Sometimes we miss them. Then the patient is having a high viral load. If I miss that also, then the CD4 count keeps declining. And the final thing is the clinical status goes in a decline. Okay. So basic is this clinical status going in a decline is basically the stage 3 or 4 illnesses. Initially, what happens is there are OCs or some small things that are popping up. Usually, we don't do a viral load less than a 1 year in first line. We don't do a CD4 also regularly. So it's very important for us to assess adherence nowadays, because if I am doing an annual viral load, maybe that the patient is already failing for the last 10 months. Maybe because of the adherence issues and other issues, he or she is failing. And though the guidelines are telling us that if a patient is stable, I do not need to repeat the CD4, but it is the discretion of the physician ARTMO to decide whenever he or she is suspecting that no, this patient may not be so adherent. He is traveling so much. He or she has so many social issues. He has depression issues with his job going away. He has lost his job. So we might always go for a CD4 count. That's not a big issue. So because these are indicators that help us to identify our failing patients. So viral load is providing the earliest and the most accurate indication of the treatment failure. This helps reduce the accumulation of drug resistance mutations. Measuring the viral load can also help distinguish between the treatment failure and the non-adherence. So if the viral load is high, the CD4 is going down, mm, we might be having that the patient does not have a proper clinical failure. But what is happening is there might be some time to recover the viral load, to recover the CD4 count. So it is very important that before we have this clinical failure, that is the opportunistic infections cropping up, we can take hold of these patients. We can basically prevent these patients from going into the clinical failure. So it is our target that to identify the virologic failure, to identify the adherence gaps, to identify the CD4 going down, and before the patient is going into a WHO 3 or 4 illness, we might really halt that process. And the instance once, even if the graphs are showing a dip, it might again take a rise. So that is the opportunity of a ARTMO or a ART counselor, how we can like prevent the treatment failures in a patient. Now, the viral load testing, as we know, for first line, it is done after 6 months of ART and then annually. And for second line, it is always done every after 6 months. So for transitions, we know that the viral load is important, and we repeat a viral load after 3 months of ESC. And for pregnant women who are on ART, suppose I have a pregnant woman at my ART who is regularly on ART and she has conceived. So in those cases, I might do a viral load in the first trimester. That is the discretion of the physician, but that is very, very helpful to identify the early failures. And then, but even if I am, whether I'm doing it in the first or second trimester or not, it is a mandate to do it in the eighth as a month of pregnancy. Between the eighth and ninth month of pregnancy, it is a mandate. We have to do that. Most often we get to hear that the patients are not able to travel. The patients are not feeling well because they are into their eighth or ninth month of pregnancy. Then we can take the help of our CSC and our outreach workers, or we can ask the caregivers of the patient to take the vial from the ART center and collect the blood. But this test at 32 to 36 weeks of pregnancy has to be done because this is a determining factor for HIV transmission to the baby. And as we all know that during the time of delivery, there is a maximum amount of exchange of blood and fluids between the mother and the child. So this also helps us to determine the prophylaxis for the baby. Now, coming to the OM, we have all seen this. This talks about the ESC. If the viral load done at regular intervals is less than 1,000, then we continue doing the viral load as per protocol. If it is more than 1,000, we will sit with the patient for 3 sessions consecutive. The counselor has to note down it in the annexure 5. In the annexure 6, in the register, we have to write down the details of the PVL, the CD4, and the reasons for the failing. And the counselor has to go through the enhanced adherence counseling sessions, and the causes behind the poor adherence need to be documented. What measures she has taken, how she has counseled, if the doctor is also involved in the counseling, the modus of counseling, what are the factors we have found leading to the poor adherence need to be seen. Now, coming to the like if the repeat PVL has to be done after 3 months of ESC, and we call this the ESC 1. Suppose even after 3 months of ESC 1, I find that the patient has poor adherence. He is again talking of some issues relating to poor adherence. Then, uh, upon the discretion of the ART counselor and the physician, whoever is there, we can go into ESC 2. So there is another 3 months of counseling, another 3 months of documentation in the annexure 5, and we need to uh, find out ways to sort out the reasons for poor adherence. That is very, very important. The timing can be changed. It's not necessary that the TLD has to be taken only at night. Patients can always take the single pill medicines in the daytime, whichever is convenient. TLD has no relation with food. We can always counsel our patients, and the concurrent medications, other drugs which he is taking, other OIs, other issues has to be sorted out by EAC2. And after EAC2, yeah, we have to go for a viral load, whatever is the adherence percentage. That is very important take home message for today. ESC1 is done. The adherence is poor. I did not go for a viral load. ESC2 is completed. Whatever is the adherence, I will go for a viral load, and this viral load will be shared with COE or SACEP. Because uh, if even if after ESC2 the patient is not showing any improvement, it is best that the patient visits SACEP or goes through the online SACEP to talk to some other experts. Like sometimes it happens that when you're talking to few fresh faces, no, a few new people talking about your adherence, your treatment and illness, it gives some amount, some impetus or some boosting. So to boost things up, to help the patient understand the importance, why so many people are worried about his ART intake, after ESC2, even if the adherence is poor, refer your patients to SACEP. Okay. So this is the gist of the OM on for 2nd of May. And now talking about the ESC, as I said, that it's best that for all ESC2s, we have to involve our SMO and MO, because they will be the best judge to identify the drug interactions, interactions with other Ayurvedic, homeopathic medicines, any other alternative treatment. They will be the best judge to identify any local issues like esophageal candidiasis, any CMV esophagitis or ulcers in the mouth, any other neck swellings, anything that are deterring the proper intake of medicine by the patient. Okay, and then the SACEP will look into the cases. Now, when a PLHIV should be referred, when should a PLHIV be referred? As I said, when the viral load count is going above 1,000, and when the e-referral has to be made within 2 days of receiving the viral load report, and SACEP will get back with the reply within 1 week of the receiving the referral. So now decision about the third line initiation has to be taken by COE, and COE will review the case, and the medicine can be given by the ART plus centers. And upon discretion, like few ART plus centers have also been authorized to decide about the third line medicines. Now, coming to the drug interactions, I was always talking about the drug interactions, what are hampering. Now, there are hepatotoxic drugs, drugs which are causing jaundice, drugs which are hampering the normal life of the patient, and as a result, patients are not taking their medicines. Now, hepatotoxic drugs mostly are the TB drugs or the ATD drugs. As we know, the INH, rifampicin, pyrazinamide especially are notorious for causing hepatitis. So these are hepatotoxic drugs. Fluconazole, very commonly used in our ART system, is a hepatotoxic drugs, and cotrimoxazole, not to mention, is also a hepatotoxic drugs. So if
Requesting participants to kindly bear with us. Ma'am will join shortly.
am I audible, Sweta?
Yes, ma'am.
Oh, I'll continue. Okay.
Yes,
Sorry, we had a network issue, I think. So I was talking about the drug-drug interactions. Now, since we are always telling that it's very important to identify the drugs which are interacting with our ARVs or hampering the minimum blood concentrations of the therapeutic concentrations of the ARVs. So the identifying what are the contraindicated drugs or which drugs need to be shifted according to a time slot is very important. As I said, aluminium, magnesium, calcium containing antacids administered the dolutegravir at least 2 hours before the antacids or 6 hours after the antacids. So it's easier, like, talking about 2 hours and 6 hours is very difficult for our patients to remember them. Some thumb rule systems, like when we work at our ART centers, we have patients of all age groups and like all spheres of life coming into our ART centers, and it's not possible for patients to remember +2 hours or -6 hours. That's difficult for them. So if we are like spacing out, like usually what how we counsel our patients is, please avoid these medicines after sunset. If you are taking dolutegravir at around 10 p.m. in the after the dinner. So these are the thumb rules, which are the easy methods of reckoning that these are the things you need to avoid. So the liquid antacids containing aluminium, magnesium, and calcium, they can be taken in the daytime, not after sunset. If you have a TLD dose at after around 10 p.m. or 11 p.m. And the polyvalent cation supplements, what they do is basically they chelate our dolutegravir, so it is to be avoided. Preferably, if you are talking to a physician, it's always easy to explain that dolutegravir needs to be taken 2 hours before the polyvalent cation and 6 hours post the polyvalent cation. Okay, so that is one method of counseling people who are finding it easier to understand. For rifampicin, we know that it is a cytochrome P450 inducer, and rifampicin decreases or lowers the blood level of most of the hepatic metabolized drugs, and so the concentration of dolutegravir, which is also metabolized by hepatic the route, is also compromised. So if we are taking rifampicin, if my patient is on ATD with rifampicin, the dolutegravir dose has to go by double. It has to be a twice daily dose. The carbamazepine is also similar with rifampicin. It decreases the dolutegravir dose. Metformin, with dolutegravir, metformin should not be given in a dose of more than 1 gram. I will tell why. Because metformin and dolutegravir, they enter the cells through the same route of that is receptors. Okay, the transporters are the same. That is the cationic one transporters. And if I take a high dose of metformin with dolutegravir, what happens is the metformin blood level, it increases very sharply, because the cationic 1 transporter is the same transporter which is allowing the entry of metformin and dolutegravir, and there's a competitiveness between the two drugs to enter the cell. So what happens is there is a accumulation of the drug either in the blood or in the cell, and so either dolutegravir blood level may decrease or the metformin blood level may sharply increase. So metformin should not be given in a dose of more than 1 gram per day. Now, coming to the PI, we know by now that the astanozole, cisapril, fluticasone, indinavir, lovastatin, simvastatin, and terfenadine has to be avoided. Rifampicin decreases the concentration of the PIs. We cannot use the PIs with rifampicin. Atorva, as we know that atorvastatins, like we have to give in the lowest possible dose, because the protease inhibitors, as of now, we have atazanavir or darunavir or lopinavir. They are the boosted PIs. Okay. So ritonavir is a cytochrome P450. Again, that's an inhibitor. Like as I said, rifampicin is an inducer which decreases the blood level of most drugs. Ritonavir is the diametrically opposite. It is a inhibitor. So when you have ritonavir in any of your ARV regimens, we can take it for granted that all the hepatic enzyme, hepatically metabolized drugs will have a sharp increase in the blood level, because the hepatic metabolism is slowed down. Okay. So atorvastatin we have seen, which is given in the common patients for 20 milligram or 40 milligram. But in the case of patients who are receiving ritonavir, a 10 milligram dose is more than enough, because otherwise there will be toxicity. Now, coming to the atazanavir, we also know that it has a problem with the PPIs. We will not give PPIs with atazanavir. We can give the H2 receptor blockers. There also, H2 receptor blockers has to be given 2 hours after atazanavir, or it can be given at a gap of around 1 hour before that. Best is to avoid atazanavir in the case of patients who are dependent on PPIs, or we can change the like counsel our patients not to take PPIs or H2 blockers. If it is possible, we will stick to atazanavir, ritonavir. So if my patient is a chronic case of dyspepsia or having a reflux esophagitis who is dependent on the PPIs or the H2 blockers, it is best to avoid drugs like atazanavir, ritonavir, because patients will be hopping from one physician to the other, and there will be co-prescriptions of PPIs and H2 blockers, and eventually there will be the decrease of gastric acidity, and the atazanavir absorption will be hampered. So this is this example how we'll take ZL ATVR. We will be taking ZL in the morning, and the H2 blockers can be taken in the morning along with the ZL. But the evening dose preferably should be avoided with atazanavir. And for ART naive patients, famotidine or the H2 blockers can be taken in a dose of 40 milligram twice daily. But for ART experienced patients, it should not exceed 20 milligram twice daily. Now, carbamazepine, the interacting drugs, contraceptives, buprenorphine, norbuprenorphine. So for most of the drugs, there are the increases of concentration due to ritonavir, as I said. Ritonavir is a cytochrome P450 inhibitor. It increases the blood level of buprenorphine, buprenorphine, carbamazepine. And with the contraceptives, it is a very interesting feature is atazanavir, ritonavir, super boosted atazanavir, it decreases the dose of estrogen, that is ethinyl estradiol. Okay, but it increases the dose of progesterone. So if a patient is on contraceptives, we have to be we have to have a very clear concept that if it is a contraceptive with only estrogen, or the patient is taking only estrogen preparation for any reason, the dose of estrogen need to be increased, or it has to be minimum 35 micrograms. But if it is a progesterone estrogen combination or an OCP, uh, birth pill the patient is taking, in that case, we do not need to increase the dose of estrogen because the progesterone dose is elevated and the estrogen dose is lowered, and it will balance the OCP function. If I am clear, atazanavir, it decreases the dose of estrogen preparations. It increases the dose of progesterone preparations. So only progesterone preparations will have a higher AUC, higher blood level. Only estrogen preparations will have a lower AUC or lower blood level. So, but if it is a combination of estrogen and progesterone, then we do not need to handle or intervene because those drugs will balance each other. But for the other drugs, there is a likelihood that the blood levels will increase. Now, coming to the adverse drug reactions, we have acute, subacute, and the late. So, acute is immediately after the ARV, subacute is few weeks to 6 months, late is more than 6 months. Now, coming to the adverse drug severity, mild, moderate, severe, serious. Now, the grades we know for mild and moderate, we rechallenge the drugs, observe the patient under close monitoring. For severe grade 3 and 4, for 3 also, we will rechallenge and dechallenge, like we continue and discontinue depending on the SACEP evaluations and the observations. And but for potentially life-threatening side effects, adverse reactions like the grade 4, which are usually the Steven Johnson's, which are the basically the when we have a toxic epidermal necrolysis, or patient is having severe fever, or patient has had AKI or some very detrimental side effect, then we will never rechallenge the drug. We will always go for another class of drug. We will hospitalize the patient, we will stabilize the patient first, and we will never ever rechallenge the drug. And remember, or we have also we to remember that abacavir, once a rash is or a side effect is documented, can never be rechallenged in the lifetime of the patient. So the take-home message is abacavir hypersensitivity, if once documented, it cannot be rechallenged in the lifetime of the patient. Now coming to a summary of the NRTI side effects, we know tenofovir has a nephrotoxicity, reduced bone mineral density, Fanconi syndrome, that is the reabsorption at the proximal renal tubule is hampered. As a result, all our glucose, uric acid, all our proteins, albumin, and the phosphates are lost. This is the Fanconi syndrome, and rarely AKI can also happen with tenofovir. Abacavir has a very widespread hypersensitivity reaction. It can have skin rashes. It can have a respiratory distress. Patients can also present like GI, acute GI problem, and pain abdomen, diarrhea, and very vague complaints of having a distension of the abdomen. So these are abacavir side effects. The best method to identify is to identify the temporal relationship with the drug. Patients will tell you that if I am taking abacavir at 10 o'clock in the morning, the symptoms of having a feverishness, malaise, pain abdomen, or the respiratory distress, or some high temperature, that is appearing after 1.5 2 hours. Again, it is waning off by the evening. Again, it is reappearing with the second dose of abacavir in the night time. So these are the very distinctive clues that tell us that the patient is having a temporal relationship with abacavir. Now, cytovirin, we all know that they have GI symptoms, malaise, and the important ones are anemia and the bone marrow suppression. And the lamivudine has a skin rash. For all these cases, we have to refer to SACEP, and SACEP will decide about the alternate drugs. Now, integrase inhibitors, we have dolutegravir. It has the GI effects, insomnia, and hepatotoxicity. We have to remember there are few 3 to 4 cases of rash with dolutegravir also. PIs, atazanavir, darunavir, and lopinavir. As a whole, PIs have this problem of hyperglycemias, hyperlipidemias. This is common to all the PIs, mostly with the darunavir and atazanavir. Atazanavir specifically has the problem of unconjugated hyperbilirubinemia. If the patient is going to an unknown doctor and a local physician, the patient will be told by the physician that you are having jaundice with your ARV, but it is not jaundice. It is just nothing but the metabolism that is being hampered at the ATP glucuronide transferase level. And as a result, the patient is having unconjugated hyperbilirubinemia, and this patient is not having jaundice. This has to be clarified very clearly, otherwise adherence will not be good. Now, coming to a few cases I will be discussing in short, because looking at slides and presentations is not that so interesting always. So there are only 5 cases I will be discussing, how we receive the SACEP referrals and how SACEP proceeds with the cases. This is a case of ART initiation where we had initially a long time patients with ZLE, then shifted to SLE, then SLN, TLN, TLE, and subsequently patient was given tenofovir, lamivudine, and dolutegravir from 2021. Now, the case was referred to SACEP because patient was having a high creatinine. It was initially marginally high, and then there were small incremental doses. Now, if you look into the referral, this is a true referral sent by a referral center. There is written history of taking metformin in a dose of 2 gram per day. And there is also inorganic phosphate, that is 2.3, uric acid is 2.7. There is routine urine examination was done, protein was 1 plus. Okay. So EGFR was 47 and patient has diabetic nephropathy. CD4 is good, it's more than 500, and virologically also the patient is suppressed. Now, the second page of the referral, here we have the total counts, these are fine. I will look into the creatinine only. In 2012, 13 and all, patient was having a more or less good creatinine level. In 24, he was detected to have a marginally high creatinine. Now coming to the SGOTPT, everything is normal. Patient is non-reactive for hepatitis B and C. That is also important. I'll tell you why. Now, patient is on TLD. He's a known diabetic on oral hypoglycemic. Recently, he was shifted to the insulin also. Now, he was complaining of lower limb weakness. Serum creatinine showed elevation, a gradual elevation. Inorganic phosphate, as I showed you, it was 2.3. Uric acid was also around 2.3. And the urine shows 1 plus proteinuria and EGFR is 47. So the take-home message from SACEP was the patient is taking inadequate dose of oral hypoglycemic because the diabetes was not controlled. So he had to be shifted to insulin. Along with that, he was taking a dose of 2 grams of metformin, which I had explained earlier, that it is to be avoided. 1 gram of metformin is more than enough. Otherwise, he will have a toxic high level of metformin, and there will be the side effects of metformin toxicity. Now, there will be GI disturbances and all. Now, counseling regarding the proper dose of ART was done. Oral hypoglycemic was also done. How to space the drugs, he was explained, like if you're having any other, like because when patients are having these side effects, we also need to inquire what are the other drugs you are taking. So this was basically hypophosphatemia, hypouricemia, normoglycemic, that is a patient hyperglycemic, sorry, and the patient was hyperglycemic, and There was also blood sugar and protein in the urine. And now this was diagnosed as a case of tenofovir toxicity. If we go back into the history, patient had a limb weakness. Patient had a proximal limb myopathy. He was not able to get up after squatting on the floor. He was having difficulty walking. That is the claudication. After walking for some stretch, he needed to sit down. So this was nothing because of the basic bone demineralization was also happening. So the tenofovir was taken away. This was a case of tenofovir induced proximal tubular damage, and there was the loss of phosphate, uric acid, and the glucose and the proteins, amino acids in the renal tubule, and that was leading to the hypophosphatemia. So the tenofovir was taken away from the ARV regimen. It was substituted with abacavir, and because we were going through a single drug substitution, this is very important. We needed to recheck the viral load, and as we know that tenofovir and lamivudine also acts against the hepatitis B, the hepatitis B status was also rechecked. So this is the case of tenofovir toxicity. We added phosphates, that is the phosphate sachets were given to this patient, and patient improved remarkably over a period of 4 to 8 weeks. Now coming to this discussion that I said, tenofovir induced renal damage, and this is basically sometimes the kidney biopsies and all are done in the higher centers, because if we are not able to identify, so now the tubular proteins are lost, bicarbonates are they are lost in the proximal tubule, as I said. And basic thing is that uh, it's a reabsorption issue and hypophosphatemia. If it is long standing case of hypophosphatemia, there will be calcium from loss from the bones, and as a result there will be the bone demineralization, and the patient may also have the easy fractures. So the patients also need to be given the calcium supplements along with the phosphate supplements. But for calcium supplements, we need to remember that we have to maintain a gap of 6 hours from DTG. Now, my next case will be like, it's here again, the patient was started on ART with TLE in 2020, and the patient was switched to ZLD as second line because she had virological failure, and there was a very rapid switch, as you can see. TLE was given for only 1.5 years, and there was a rapid switch to ZLD, and the adherence mentioned by the referring ART center is 98.9. It's pretty good. And then there was this viral load, and the viral load showed that there is a after see the second line was done in December 21, and after December 21, there was one viral load that was showing virological suppressed in the month of September 22. That is also delayed, like it should have been done at the end of 6 months. Again, a repeat viral load was done again next year after 12 months. And there also there's a documented delay, because for second line patients, we have to do our viral loads at intervals of 6 months and not 12. And the second viral load in 2023 showed a very high count of 1,44,000. Patient had a drop in CD4 count also. And after evaluation at SACEP, we rechecked the viral load. It was high. We shifted the patient to third line, and we had sent the sample for a drug sensitivity report. We at COE STM, we had the facility of drug sensitivity report at present because of collaboration or study with NICED Kolkata. So from that, we received a report like this. See, patient was on TLE as first line. Here, TL and efavirenz all are still potent. And second line was ZLD. That also we see dolutegravir is potent, zidovirin is potent, and lamivudine too. So the inference was only raltegravir, it's not showing properly, has a few minor mutations. Apart from that, all the class of drugs are sensitive. So no mutations with NRTI and PI, with raltegravir only, which the patient never got. Fortunately, there was a minor mutation, and so this patient was after 1.5 months of third line, patient was shifted back by SACEP. It was a very sensitive and a very uh, decision that involves some amount of risks. SACEP decided that the patient should go back to first line, like not exactly first line, but TLD regimen. And there was a very close observation done. Because it was a risky decision that we took, so the viral load was repeated at 3 and 6 months of ART, and it was always suppressed. So the take-home message is the first line shift from first line to second line was done very rapidly within 1.5 year. The failure after second line was also very rapid within a span of another 1.5 year. So it shows that the adherence, though it was documented as 98.9, it was never true. If the adherence was good, there would have been mutations which would have cropped up. No mutations show that patient did not take medicines. Okay, so adherence is very important. Now coming to the case 3, here this is a pregnant lady who presented to the ART center in her second trimester of her pregnancy in April 2024. After that, the viral load was planned after a period of around 4 weeks. The ART center thought that we will do a viral load. It is not advised to do a viral load after 4 weeks, but however, it was decision of the physician there. But what happened, unfortunately, around 4 weeks time, the pregnant lady, she had chicken pox, and this led to her a notion that, oh my god, I took the ARV drugs, and then I had chicken pox, and people told her, all other people, other information sources told her that chicken pox will be affecting her baby. uh, True, chickenpox might affect babies, but what she did was she stopped taking her ARVs, and then she was almost missing all her ARTs, and only her husband was coming for the pill pickup. ART center was in a like very difficult situation; they could not contact her, and then they called back, they got in touch with COE, and we advised to get in touch with her. And at 32 weeks of pregnancy, a viral load was done. She was again started on ARVs, but the adherence was not good. Actually, we could not motivate her initially to continue with her ARVs. Like the motivation was like counseling was not adequate. Like she wasn't confident that the ARVs were not doing any damage to her. So the referring ART center got in touch with us, and then uh, we asked them to present the case as online SACEP. We often ask the patients to sit with a Google Meet from their convenience of their home. Patients do not have to come to us. The ART center was in the online SACEP. The patient, because nowadays most patients have smartphones, the patient also logged in from her home, and then we spoke with her. We counseled her that, see, what you're doing is will hamper your patient, hamper your baby. Your in the expected time of delivery was approaching. It was in the month of September, and we really had only a few weeks time in our hand. So after a lot of counseling that we really need to have a negative baby, please consider taking your ARV pills. It will not harm you anyway. And we also spoke to her spouse and her family members. Like it was a general counseling for all of them, because this chicken pox and the ARV together had created a lot of problem. So after that, the patient continued ARV for 4 weeks. And just before the time of delivery, we got a viral load report that showed that patient was suppressed. Okay. So this is the 23rd of September. She had her EDD. And the 3rd of September, we had a viral load report that showed suppression. So the take home message here again is that we need to counsel our patient at their convenience sometimes. There are there will be issues like other co-infections which will trouble the patient. IRIS may happen, which will trouble the patient. Sitting with them regularly, talking to them via Google Meet, we will not keep calling the patients to the ART center. Counselors can call up the patient's telephone call and ask them the issues. And for pregnant cases, as you could have seen here, the home center was very effective in contacting COE almost every month about the case, and we like helped them to achieve the suppression, and the patient like she delivered at the end of September. Now the case 4, again this is a case of dolutegravir induced transaminitis. Patient was on TLE for quite some time. Then the patient was shifted to TLD. As you can see that the SGOT, SGPT, uh, during the time of IPT, as we all know, there is sometimes a slight elevation of transaminases. But after IPT also, it was 1.5 times to maximum 2 times of normal. But once the drug was changed to dolutegravir, there was a sharp increase in the SGOT, SGPT levels, mainly the SGPT in this case. We also have cases where the SGPT goes to around 400, 500, and 600. So a patient was also alcoholic. This case was presented to SACEP. SACEP evaluated the case. The patient had a good CD4 virologic suppression. And here, SACEP kept on observing the patient at every 2 weeks interval, 4 weeks interval. We checked the whole hepatitis profile. It was negative. She had no hepatitis nowhere, not even E and A. Hepatomegaly was there. Portal hypertension was excluded. Stone strictures were excluded. PT-INR was done to check for the bleeding and susceptibilities, and we also went to see whether she had after examination splenomegaly or not. Then the repeat LFT was done after 6 weeks, and we shared it with the home centers. And then uh, uh, the patient was ultimately like what we did was we counseled the patient to avoid alcohol 100%. And after counseling, the reports gradually they started showing a decline. So we also have another report that has not been shared. Now the patient is having a normal LFT report. Here the SACEP take-home message is we have to screen our patients for hepatitis profile when we are seeing a case of deranged LFT. We need to look into PT-INR, USG whole abdomen, and the dolutegravir may be an offender. Trimoxazole is also an offender. Other hepatotoxic drugs, as I said, the ATDs and the fluconazole need to be evaluated, and the close follow-up of the case has to be done. And in many of our cases, we have found that dolutegravir does not like alcohol. Basically, alcohol and dolutegravir are not at all friendly. They together give a sharp rise in the SGOT-PT levels. So we have to remember that if a patient is a chronic alcoholic, keep counseling him not to take it, because dolutegravir and alcohol are too like simple. They are two foes together, and they lead to derangement of LFTs. Now coming to the last, I've discussed this. Now coming to the last case, it's just a case of drug rash. Here, basically, patient was started on TLD, and on the same very day, patient was also started on INH prophylaxis on the 20th of March 23. Then patient presented to the ART center after around 4 weeks with rashes all over the body, macular papular rashes with few small blisters, and rashes all over the face, itching, very, very itchy rash. That is what we call prurigo. And here all the drugs, including IPT, was withheld. The patient was referred to COE, and then luckily the ART center was a very good. It's a Bardhaman ART center. I'm naming them. They are very good at referring centers, and they um, also took snaps of the rashes. The pictures were shared with COE. And the patient was also referred to the dermatology OPD. I'll share the rash picture. This is almost in the healing phase. Like this was the phase when the TLD was already stopped. There we can see the dry excoriations and the peeling off of the skin. It was an extensive rash and with intense pruritus. And now coming to the see if you can see something here, like here, sorry, there is a dermatology prescription. The SGOT levels has gone up to 266, SGPT has gone up to 370. It is a drug rash with systemic symptoms. Okay, drug rash with systemic symptoms and eosinophilia, because here you can see that the eosinophil count is 4% and the SGOT-PT is quite deranged. So this is what we call the dress syndrome, where the drug rash it extends to involve the systemic symptoms, systemic our systems. So the liver is also affected. Also, our eosinophil, our whole system starts fighting against the drug rash. Now, the patient, as I said, he was having a very severe drug rash, so he was treated with oral steroids and topical steroids, and then all the drugs were stopped. So INH was also stopped, and then what SACEP did was the patient was given only TL for 7 days, and the drugs and the rashes reappeared within 24 hours. So the drug was stopped. Patient was given a telephone number from our end, and he was told to report to us whenever we had rashes. That's also very important for these cases. Now, then we gave a trial with, we stopped for another 7 days. Everything was withheld, even the cetron and everything. Then we again gave a trial with tenofovir and dolutegravir, and this was tolerated. Now, the inference is thus if the patient is tolerating D and T and not tolerating T and L, that the only offender drug remains is lamivudine. So this is a identified a case of lamivudine rash, and now the patient is stable on a lamivudine sparing regimen, that is AZT, tenofovir and dolutegravir, and he no more has rashes. And one take-home message here is sometimes we have seen from few ART plus and other centers that the patients are re-challenged during the trial of rashes with monotherapy. But monotherapy has to be avoided as far as possible, because monotherapy gives rise to early resistance to that drug. And monotherapy with lamivudine should be avoided at all cost, because lamivudine has a very low genetic barrier. And if I give my patient only lamivudine for 7 days, take it that the lamivudine is lost for lifetime. So the take home message here is the preferable challenge should be done with 2 drugs at a time. If I am fortunate to identify the offender by this method, it is okay. But tenofovir and some other drugs like AZT can also be given for a week monotherapy, but never with lamivudine. That is very important. And as far as possible, we will avoid monotherapy. We will be trying permutation combinations like this TL, TD, and we have to identify by subtracting which was the common factor. So that here it is established that T is not the offender and D is also not the offender. So that is the end of my discussion today. These are the references, and thank you for listening. If there are any queries, I'm always there at COESTM. You can always email us at coestm1@gmail.com. We also have our EPAN number 89024999487. I know sometimes we always go back to our RDLSs. We listen to it by the recorded links and all. So please get back to us if you have any queries. And thank you for listening.
Thank you so much, ma'am. Ma'am, there's one question in the chat box.
Yeah.
A child who is on ALD as per weight band, when he
Yes.
achieves weight of 30 kg, should we straight away substitute to TLD?
No, we will not shift the child to TLD. Basically, if the child is doing well on ALD, he or she is virologically suppressed and has no issues with abacavir or dolutegravir, we will not shift, because the NACO guidelines never tell us that the shifting has to be done just because the child has moved from childhood to a 10-year or 12-year period. Okay. This shifting will not be done because, when you are patient, because children are continued on ART for lifelong. So they have years and years to go. So we will be preserving as many as drugs as possible. So tenofovir we will preserve, which is a very good drug and one of the best efficacious drugs. So if my child is doing well on ALD, I will preserve him with my ALD and not unnecessary. I will not shift. Okay, is that clear? I hope so. Any other questions, Sweta?
Hello,
Yes, sir.
Yes. Yes, sir.
Madam. Good afternoon. Myself, Dr. B.N. Tripathi, Senior Medical Officer, Bhubaneswar.
Yeah. Hello, sir. Tell me.
Sir, this was my question actually.
Okay.
And another question is that in case of allergic reactions,
Yes.
of particularly higher grade allergic reactions,
Yeah.
we need to titrate different permutation
Give a
combinations.
trial. Give a trial with the drugs. Yes.
For that, we need to get supply of individual drugs for that.
Yes. That is true. We need to have individual drugs like for tenofovir, individual tenofovir that is available at the COEs. So you can always refer the cases to COEs. We will take over. COEs and few of the
Is,
ART plus centers also have single drugs.
is that available? That was my question actually. Is
Yes.
that available in ART Plus centers? I am from
Yeah,
Odisha.
few of the ART plus also have the drugs. I think Kotak also has few ART, tenofovir and AZT drugs. Yeah, they have.
Okay, okay, okay.
Okay. But
Thank you.
if they, by chance, if they are not having, okay,
Okay, okay.
sometimes what happens is they do not have patients, or maybe the existing samples, supplies have expired or in those cases, you
Yes.
can always refer to the COEs, because we always have a single formulation of tenofovir, AZT, and lamivudine with us.
Can we directly approach the COE for individual supply if it is not available in our ART Plus center?
Uh,
ART
not
center as
not
as
I
ART
don't think
centers.
that no, I
Can
don't
we
think you can
directly
directly
approach
approach.
COE?
I don't think so. I think you have to apply through yeah, through your Yatis class center.
Okay, okay, okay.
Okay, sir.
Thank you. Thank you.
Okay, thank you.
Nice presentation, ma'am.
Thank you so much.
Thank you, sir. Any more questions from the participants? Please feel free. आप unmute कर सकते हैं या फिर आप chat box में भी लिख सकते हैं. सैसेप या टेलीसैसेप को लेके किसी के भी कोई सवाल हो?
I think not now. We'll ask
Yeah.
later on.
Yeah, thank you so much, ma'am, for
Thank you,
facilitating this
Sweta.
session. Thank you to all the
Okay.
participants for patient listening. We'll conclude this session now.